I think we're all set. Alicia, so you want to kick us off?
Great, thanks, and thank you all for joining us today as we talk about how Michigan Medicine and UMMG are doing the social determinants of health screening through the Partners in Care Questionnaire. Next slide, please. Thanks. So our agenda today is we'll first do some introductions. We'll talk about how we identified the problem, how we went about understanding more about what the problem was and what we were trying to fix, defining our standard, changing our future, and then what the challenges and lessons learned were from that whole effort. So today, Amin and I are presenting. Amin is a continuous improvement specialist, and he's been really integral to all of this work, really kind of taking it on and helping us with the analysis and then helping with all of the implementation. And I'm Alicia Meyer. I'm the Administrative Director of Care Management for UMMG. I have a dual role with statewide Michigan Institute for Care Management and Transformation, which is a Blue Cross funded coordinating center. And so I have a lot of the social work and the care management side of Partners in Care Questionnaire and trying to think through that side of things. So the problem, social determinants of health account for 80% of health outcomes. And this is kind of the idea that while we give great advice here, people lead their own lives at home and day to day. So for however long we have them here, we can give all sorts of things that we want to have happen. But if the rest of the world doesn't align around that patient being able to do what the plan was due to either access, healthy behaviors, their physical environment or other socioeconomic factors, then we'll have poor health outcomes and increased health system costs. And so in order to identify whether or not there are these barriers, we have the Social Determinants of Health Questionnaire. And at Michigan Medicine, we've been screening in primary care for quite some time. There was a state innovation model project that's been going on. It went on from like 2012 through 2018. And through that state innovation model project, we created the Partners in Care Questionnaire, and we got it going all throughout primary care. And the way that we designed it is it was a screen that was completed at all of the annual wellness visits, and it relied on the clinicians at that time of screening to submit referrals based on what the patients needed. And while we were doing a good job with screening, what we weren't doing a good job of was following up with the patient and making sure that they got the referrals that they were needed. And you can understand that there's probably a lot that goes into that. If you come in and you fill out a questionnaire, what are the odds that questionnaire is added into the chart by the time the provider gets there? Pretty low. And so there was a mismatch. We knew what the barriers were, but we weren't able to connect people with the resource following that barrier. And why are we looking so much into this now? It's the right thing to do. It's central to our base. So belonging, this is one of the goals of UMMG, is to have this screening be conducted across UMMG. There's a joint commission requirement for IPV screening in ambulatory areas. So not only are we recognizing that this is a major thing that we want to have happen because of our base goals, joint commission is also requiring this kind of screening, and IPV or interpartner violence is one of the sections on the Partners in Care Questionnaire. So it's aligned there. And also there's a lot of payers that are looking at this and requiring information or paying for information around social determinants of health screening, mostly in Medicare and Medicaid. And also there's a huge focus on inpatient side as well from the Joint Commission to start screening and start reporting on this information.
So I can take it away now. So as we begin understanding the problem, so we know we have some background information as to why we should be kind of focusing on social determinants of health and what interventions we can apply. The question that started to really come was, why is our current process of screening not working? What is that lack of transparency into the data? Alicia had mentioned, we don't really know how well the referral process was actually working, and even just standardization of the Partners in Care Questionnaire screening wasn't super clear or well-defined. And so one of the tools that we were able to use is this fishbone diagram that's displayed on the screen right now. And what it really allowed us to do is start thinking through some of the challenges that we are experiencing with the process and starting to bucket them into different categories. I think with problems such as this one, where we have a process and we can't necessarily determine why it's working, it's helpful for us to start grouping our barriers by category. That way we can determine what interventions make most sense and we can start targeting them in a systematic fashion. So some of the things that we had identified is there were multiple screening tools. So at one point there were 2 different versions of the questionnaire that were being pushed. And I think that that's one of the big things that we've focused on in the last few months is there's just one questionnaire that follows the same workflows. So everything on the MyChart logic side kind of follows one standardized workflow. So no more questions surrounding that. There's a ton of variation in how individuals were referring to the different resources. So on the next, in a few slides, you'll see all the different resources that patients might have access to. But if you are someone that isn't super familiar with the social determinants of health model or doesn't really understand what each of the different resources provides to patients, it would be incredibly difficult to understand where you should be sending these referrals to. So again, it's not necessarily the fault of anyone, but there was just a ton of variation in how people could be sending those referrals. Didn't really help anyone at the end of the day. There was a kind of survey that went out that said only 20% of physicians were confident in their ability to address their patients' unmet social needs. So an incredibly low number. And that kind of drove us to ask the question, should this really be within the physician's hands? Does it make most sense for physicians to be the ones sending the referrals? Or is there a better way to kind of standardize this process so that physicians will be involved, but won't necessarily be carrying the brunt of the work in terms of actually sending the referrals? And there's also a lot of kind of question on the patient's end of what resources should I be taking advantage of as a person? Can I refer myself to any of these different resources? How does that work for me as a patient? There's a lot of, I should say there was no standard work or lack of standard work to determine which resources were needed. And just the referral process across providers was also super variable. So there were a lot of different issues that we were seeing within the old process. And that's where we started to think through, how do we standardize this? How do we create it so that it's one simple model that everybody has awareness of, especially as we were beginning to spread this across specialty care. So as we started to think through what our new standard was going to look like, there were those 3 key target areas that we wanted to focus on. The ones kind of circled on the previous slide, translated into, instead of screening at annual well visits, which wouldn't necessarily apply to specialty care in the same way, how do we determine what visit types we should be screening at for specialty care? And the decision was made to screen at all new patient visits. And in a few slides, you'll see a process map of how this works. But essentially, MyChart has logic that looks to see if a patient has completed the questionnaire within the past 11 months anywhere in the health system. So if a patient goes to a primary care visit and completes the questionnaire, it won't repopulate that questionnaire within their portal, but it does look to check, has the patient been screened on their social determinants of health at least annually right now? The other part that we really want to focus on was relying on clinicians to submit the referrals or physicians to submit the referrals. We were able to develop a position that is a centralized social determinants of health coordinator that sits on the care management team, who is actually the one that sends out all the referrals now. So all positive screens go to her in basket, and from there she triages them and is able to send them out to the appropriate resource, which I'll explain in a little bit more depth. And then lastly, one of the big things that we were kind of dealing with is, rather than screening at the time of visit, how do we ensure that patients have the option to have their intervention take place prior to their next visit? So what we were able to do is the questionnaire actually pushes itself out to the patient's portal a month in advance of a specific visit type. So in this case, a new patient visit in one of the areas that we've gone live in. And I'll explain a little bit more about that in detail as well. But essentially what this does is it gives ample time to patients to actually fill out the questionnaire. Most patients don't end up filling it out until a couple of days before their actual visit, but there is a lot more flexibility in how patients can fill this out. So before I jump into the actual process of how this works, I think it's important to recognize all the different resources and people that are involved in actually providing these interventions to patients. So the questionnaire itself is about 20 questions, and it asks questions across a whole breadth of different social determinants of health. So questions that go to the guest assistance program revolve around whether the patient had to skip medications to save money, if they're experiencing food insecurity or utility insecurity, or if they have a lack of transportation that's keeping them from getting to their medical appointments. And we also have specific questions that go directly to MSW. So Alicia mentioned that there's a Joint Commission requirement for IPV screening. So any of the intimate partner violence questions get sent as an urgent page to the MSW team, whether it's a centralized MSW team through Care Connect or it's an embedded MSW within that clinic. And then from there, they'll be able to provide pretty much immediate, intervention as needed. And then also social isolation questions get sent to the MSW. This community bucket right in the middle is kind of our SDOH coordinator will refer patients to local community resources on things related to transportation to get to work or meetings or just things needed for daily living. So outside of their clinical care, whether they're, if they're experiencing child or elder care difficulties, ability to find a steady source of income or just job insecurity in general. And then and we have to say an incredible thank you to the virtual care team for developing a referral process for us. We were able to ask some questions about virtual care, especially thinking through the last few years now that virtual care has, exponentially grown through the pandemic. A lot of our populations may not have access to the technology needed to, get to their visits, or may not have the comfort level to actually use those devices to join in on their virtual care appointments. So this questionnaire also asks about their comfort and kind of access to technology. And then the last one is access to patient financial counselors. So there's a bit of a difference here in that if you are skipping medications to save money, that goes to the guest assistance program. But if you need help paying for medical care, that is an email referral to the patient financial counselors who will be able to provide help once as needed. So taking all of this information into mind, we started to kind of build out a very high level process, which is what you're seeing on the screen now. And there's some major points that are kind of designated with stars here. So the first is, again, as I mentioned, rather than just this questionnaire being screened right at the time of their visit and then sort of disappearing into the void with no real clear process for follow-up, MyChart now automatically pushes the questionnaire 31 days in advance to the patient's appointment. So they have a month in advance to fill out their questionnaire. Whether they fill it out a month or in advance is in the patient's hand. Many of them do it 2 to 3 days prior to their visit when they're checking in, but there is that flexibility there. And then there's a significant amount of logic kind of running in the background where MyChart will try to understand, has the patient filled this questionnaire out in the portal? If yes, any of the positive screens that a patient screens for will be sent to the SDOH coordinators in basket, with the caveat that patients have the autonomy to select I think it's question 21, that essentially says, do you want help for this? And recently we made a change where after each of the different questions, patients have the autonomy to say, do you want help with this? So that is in place to kind of help reduce false positives. So the way that the questionnaire is set up itself is it asks, in the past year, have you experienced the following? So for example, if I experienced food insecurity in January, but am no longer experiencing food insecurity, I might answer yes to that question, but also have the autonomy to say that I do not currently need help with it. This allows patients to kind of have a little bit more autonomy in how they want to answer these questions so that they can get the help that they need. And it makes sure that only those patients that truly need help are being sent to the SDOH coordinator and then sent to our internal resources or community resources. There's also the option that patients might not complete this questionnaire in the portal. They'll show up to their visit with it uncompleted. So we developed a workflow there where, depending on whether the clinic has welcome tablets available, it follows the same standard process for any other questionnaire. And then again, positive screens are sent to the SDOH coordinators in basket. And then the SDOH coordinator kind of has a number of different steps that they can follow to understand where they should be sending the referral to for the specific patient. So for any IPV questions, the intimate partner violence questions, if a patient answers yes to it, there's some additional flow sheet rows that pop up that essentially say, what is the best method to contact you? And that's to recognize that we don't want to put the patient in any more danger than they might be in, and make sure that we're ensuring patient safety above all. And so patients have the ability to select what the best method is to actually reach out to them if they want to be contacted with any resources. And then the SDOH coordinator will send a page over to the Care Connect Contact Center, which then sends out the appropriate page to whichever MSW is responsible for that specific patient pool, depending on the clinic that they're to be seen in. For all the other questions, again, it kind of asks after each one, do you want to get connected with resources? If a patient answers yes, then it, sends over to the SUH coordinators in basket, and they'll send out a referral as needed to any of the resources that were displayed on the previous slide. So whether it's the guest assistance program, MSWs for social isolation, patient financial counselors, virtual care, or just those local resources. So far, this has been working pretty well for us. So our goal with this entire project was to at least have this implemented into 2 specialty care services by the beginning of fiscal year 23. By the end of this fiscal year, our goal is to have it expanded into all of specialty care, screening new patient visit types. So that's kind of what we're in the process we are right now of working through. We've learned a lot along the way, so we'll definitely be able to cover that. But the reason that we felt so confident in expanding so quickly and trying to get this kind of developed into the rest of specialty care is just the success that we were able to have from our pilot results. So looking at screening from March through July for primary care, there were 44,000 questionnaires completed. Of that, 11,000 of those questionnaires had patients that identified at least one or more needs. In that 762 patients said, I have a need and want to be connected to a resource or request help. But only 169 of those actually were referred within 2 business days, which is sort of the metric that we're using to measure, are you within the time span? So our metric that we're using is if a patient fills it out within that 30-day kind of time frame prior to or 2 business days after their visit, is what our target goal is for sending out these referrals. And we launched our first iteration of the questionnaire process within Domino's Farms pre-op clinic back in late February, right at the end. And so we looked at data from March through July, and in that time frame, it was only 1/10 of the total amount of questionnaires completed versus primary care. But for patients that identified with one or more needs was about 1,500 of the 4,200 patients that completed a questionnaire. In that, about 158 of them said, yes, I do need help with some of the needs I'm experiencing. And our process was able to connect 134 of them, to the appropriate resource within 2 business days. So when you look at the number of total referrals that are being ordered in proportion to the patients that are actually requesting help, we're looking at about a 60% increase total overall in our ability to send out these resources. And so from there, we started expanding fairly rapidly. And over the past fiscal year to date, so from July to February now, primary care has screened 75,000 patients and specialty care has screened about 10,000 patients. In that, about 1,600 patients total have been, either have requested help and then have been connected to the appropriate resource within that same time or kind of in that time frame. So we're already seeing pretty tremendous impact. And I think for me personally, I always have to remind myself that, each individual is part of that 1,600. There's a story behind that person. There's a real human being that needs help, and we have the ability to help them. And so we'll kind of showcase a timeline at the end of these slides of where we're at in terms of specialty care expansion, but we did flip primary care over to our new process back in December. So they've been running on the new process for about 4 months now, 3.5 months. So, and it's been working out pretty well for them. The other thing is starting to look at the stratification of data of, what are our populations experiencing in terms of need. When we look at primary care and specialty care, there are pretty significant similarities. We're seeing a really high need for social isolation support, food insecurity. And then in primary care, we're seeing a lot more job training questionnaires being filled out versus in specialty care, it's a lot more on the financial medical care. So it is a little bit interesting to start looking at the way the data breaks down in terms of where do our patients find the most need, or where are we finding that patients have the most missing social determinants of health overall. The one caveat I always say about social isolation is that there still is a little bit of uncertainty in how patients are interpreting this question. Many, I think, probably impacted largely by the pandemic, read this as, am I isolating in terms of, am I staying away from people? Am I quarantining? Which is part of the question, but I think this one is focused on something a little bit more. And I don't know, Alicia, if you want to speak to that, or if there's anything else that you want to add to these 2 slides.
Thank you. And I think social isolation, you're right, is one of our kind of wild cards. We initially thought that it was linked with suicidality and, depression. And so we were kind of worried about, how do we do that properly? But it has had just a really wide response reasoning.
Right.
And so we're trying to think through how we best approach that. But I think, as Amin, you said, what we're really proud of is that we have a process now where we hear things from patients that are like, we didn't know you responded to these things. And they're just very grateful. And these are the kinds of things that we're able to help people with and remove these barriers so that people can get care in your clinic.
Right. So then also looking at some of the kind of way that the data breaks down in terms of where our screen's going in terms of referral destination, we're seeing a really high need for access to the guest assistance program, and to kind of community resources. So the SDOH bucket that you see in the middle is those community resources that the SDOH coordinator might refer patients to. So over the past calendar year, of all the patients that screened positive for a need and requested help of some degree, about 18, almost 1,900 of the patients needed some form of gap support, about 1,500 in SDOH, and then 1,200 in MSW support. So this starts to give us a better idea too of like internally resourcing wise, where is our need? Are we appropriately staffing, where those needs exist, and what changes need to be made to ensure that patients have the access that they need. And knowing that access is kind of the big target for this year and kind of Michigan Medicine's vision overall. Now that we have a much more measurable process, we can start answering some of those questions as well. But as I was just talking about, these are all numbers and the numbers are fascinating, but I think the patient stories that exist behind the numbers are so much more crucial. So I'll turn it over to Alicia to kind of share some of the patient stories that we've received out of this.
Thanks, Amin. You always give me the fun part. So one of our first patient stories was from Domino's Farms pre-op. And this was from March when we had just started. And so there was a female patient who was 37-year-old female patient who was scheduled to have a breast biopsy. And she was sent the Partners in Care questionnaire advance of her appointment. She filled it out. And some of the background that we have on her is that she has a husband and young son. She's currently stay-at-home caring for her young son. But on the Partners in Care questionnaire, she identified several things. She identified difficulty paying for medical care, food insecurity, difficulty with childcare, social isolation, interpersonal violence concerns, and job resource needs. So there was a lot going on while she's worried about having breast cancer. So you can imagine your own situation if this was you. Thank you. And so she basically almost immediately, the social determinants of health coordinator received that. And this was when we were just starting out, so we didn't have a lot of volume at that time. But the first thing they did was send an email to the patient financial counselor to support paying for medical care. Then they sent a referral to the Master's in Social Work for the social isolation and interpersonal violence concerns, and a referral to guest assistance program for food insecurity. And they directly contacted this patient with resources for employment and childcare in her area. So there's a whole bunch of things that were immediately put into play so that this person could get their biopsy, but also so they could approach that and be able to plan their care and think about their care versus thinking about all of these other things. So the Master's in Social Work contacted Mrs. M. So she's this is an urgent referral that's placed. And so this is basically either same day or next day contact by the social worker. And the patient revealed that they had already been on a wait list to see the psychiatrist, but they'd missed their first appointment with a psychiatrist due to being hospitalized at the time. And the MSW offered to help get that person back on the wait list. But in the meantime, wanted to know if they could be connected with a behavioral health collaborative care program, which is a primary care-based program. So this patient also had primary care at Michigan Medicine. This is a primary care-based program that is a collaboration between social work, the patient, primary care, and a psychiatrist. And so it's sort of like a way to get access to psychiatry consult, but not with the patient, but like to sort of get more access there and more support. And the patient did want this program, and that person was connected in with BHCC. The social worker checked on some of the other things since they were the first person to talk, and at that time, the patient declined food assistance. Very soon after, the behavioral health collaborative care social worker contacted, set up a video visit, and began adjusting medications with the help of the psychiatrist and the primary care physician. After the social workers were engaged, the GAP shortly called within a couple of weeks, and at that point, her food benefit had been reduced and she couldn't afford her medication co-payments. And so GAP helped with an support application, supplemented her insurance, and additionally helped out with finding local food resources. So all of these resources, they already exist, but this patient wasn't able to access them until we discovered through the screening that these were needs, and we were able to connect in there, and she was able to get to her appointment. And we were addressing all of these other things at the same time. There's another example of an OB-GYN patient in fall of last year. And this was a 25-year-old woman who was 5 weeks postpartum. And she had a transition of care phone call that had no needs identified, but then she also completed the Partners in Care questionnaire and screened positive for difficulty paying for medical care, skipping medications to save money, food insecurity, worried about utilities, worried about housing, childcare needs, difficulty finding work, and social isolation. So that's a lot to have also with a 5-week-old. So this patient is in need of our support, and we were able to connect her. So the social determinants of health coordinator again received the PICU, and we had a referral to the social work, and the patient expressed alternative methods of the support through a psychiatrist at Beaumont, and she had already additional support through a private practice psychiatrist. And she had a support group through pregnancy, but she didn't have any other support groups. And so the MSW was able to connect her with additional groups and other resources. For the guest assistance program, the patient let GAP know that she's not currently working, and she was relying on support from the baby's father, from financial support, as well as support from her mother, but she was not going to be having that anymore. So GAP is working to help her with, how do I get money to pay for both my medical care, my baby's medical care, and for any medications that she might need. And then the social determinants of health coordinator directly sent this person resources for employment, for childcare, and for financial assistance that were in her area of residence. So those are the individual patient stories that are going on a larger scale. And we're trying to track all of this information. We have a Tableau dashboard, which is on the main quality Tableau dashboard site. And you can go in and see for any of the areas that are live that have data in there already. Patients with 1+ domain, patient 1+ needs, how many there are with 1 needs, how many there are with 2 needs. You can see for primary care, the percentage of patients who have been screened for annual wellness visits. And you can see demographic information. You can see geographic information about screening. You can see the questions in there. It's really a comprehensive Tableau dashboard. I have to give a lot of kudos to Mary Fisher and Julie Ziegler from the quality analytics team. They've spent a lot of work on this. And in fact, some of the inpatient data is in there now as well. And so it's a really comprehensive dashboard. You can see a lot of the work that's going on there. This is a little bit more about the dashboard. So you can see there's both a 12-month and 1-month look back. You can see which domains are most needed. We're screening for that are the highest based on your clinic or discharge unit. Whether the patient wants help or no. So you can see like what are the needs that patients are experiencing, but they don't need help right now. It's just something that's impacting their lives. And these are pieces of information that we want clinicians to have at the point of care. So you can always see the social determinants of health questionnaire in the rooming tab. You can always see it in the questionnaires area. So this is information that just resides in my chart for everyone to see. But on a sort of aggregated basis, we have it all here as well. And then our timeline, and I can't remember, Amin, if this is my slide or your side.
It's yours, go for it.
Okay, thanks. So our timeline, this is how we intend to get this screening out to everybody. What we're doing is we're working through the oversight leaders, and we're trying to tell the oversight leaders, okay, we would like to go live in your area. Here's the list of departments we think pertain to your team. Can you correct that for us? And then we get that corrected. We rely on oversight leadership to tell us, where can we present, where can we participate in your current meeting schedule so that we can help educate your team about what's going on. Then we work with MyChart to schedule that go live, and we make sure that both GAP and MSW teams are aware that this is going live. We've been trying to partner really closely with everybody to make sure that there's no surprises, although we have had a lot of lessons learned as we go along. We think we've got a good process now. Mm-hmm. But as you can see in April, cardiovascular and oncology are slated to go live. We are working actively with them and hope to see those go live soon. In May, med spec, rehab, ADTU infusion, and in June, CMC, PM&R, surgical specialties, ambulatory procedures, post-acute, and transplant. The challenges and lessons learned. As I just mentioned, there's a lot of things that we wanted to that we were challenged in getting this process going up. First of all, in our climate, getting somebody hired for SDOH coordinator resources is very difficult, but luckily there was payer funding to support that. And so we were able to hire a community health worker type of role to support this centralized position. Also, having continuous improvement. So having Amin on the team was critical. We really needed that. There's been so much process evaluation, process reworking, learning from different things, learning from the different situations that have cropped up, without having that very structured idea of we need to be documenting what we're doing, we need to be standardizing what we're doing, and as much as possible, making sure that we have all of those things very clearly outlined. Without Amin on the team, it would have been very difficult. And then without the GAP and MSW resources, GAP is a very unique team to have. Most systems do not have such a team, but it really is a great thing that we can have this team of BSWs who understand what our internal resources are, can connect out into the community as needed. But it's a really excellent group to have for our patients. And likewise, the MSWs, they are already busy as well. Both GAP and MSWs are already busy, but they recognize the importance of this work and agree to do it, even though they already have full caseloads. And so being able to have a resource to immediately connect someone who's saying that they have interpersonal violence issues, or they're experiencing social isolation and we're worried about an exacerbation of a depression situation, those things are big.
And then just challenges and lessons learned from the overall project management side, and kind of as we continue to expand, is some of the communication pathways are so critical to be predefined. So understanding where referrals are supposed to be going, who's responsible, who's responsible for those that will be responsible for the referrals, ensuring that everybody has the same information and consistent information across the board was so important. And I think something that we're still continuing to learn, how do we best communicate this out to everyone so they understand what is a Partners in Care questionnaire? How does it work? Why are we doing it? And who all is involved? To make, and again, just making sure that we have one standardized approach to screening patients across Michigan medicine for social determinants of health. Definitely, when you start looking at the aggregate data, there's a very clear need for social determinants of health screening, but it's the stories behind each of the data points that really makes a compelling argument as to why this is so critical. Each completed questionnaire is a person, and as you can see, more often than not, they're very complex situations that it's not always just food insecurity. It's not always just housing insecurity. It's often a combination of everything. And, making sure that as a healthcare system, we're doing our best to recognize that and provide that care for our patients when possible. As Alicia mentioned, process improvement is very much a cyclical experience. I think that's why I enjoy it so much, is that it does have space to go back and refine the process as you learn, and knowing that you might mess up, but that doesn't mean you're wrong, and that there's always going to be a better way to do things, and just learning what that way looks like. So I believe that concludes our presentation today. I do want to give a very special thank you to the entire planning team for the Health Equity Month. just overall, and Dr. Majay especially for her work and partnering this and encouraging this. It's been phenomenal to see this go live over the last year now that we've been working on it so heavily. And also a very big thank you to the managers of the GAP program and MSWs and everyone that's involved with this. There are more names than I can count, but everybody has played such a crucial part in this. So if you ever watch this recording, thank you.